Welcome back to Public Health Musings, where we unravel the complexities of public health challenges and opportunities. I'm your host, Dr. Caroline Kingori, and today we continue on this special series of episodes featuring contributors from a recently published book. As the editor of the edited book called COVID-19 and Public Health, I'm excited to delve into the insights provided by those who have contributed chapters to this publication. Today, we are tackling a really critical topic related to substance use and its connection to public health. Joining me are three amazing contributors to this book. We have Emma Biegacki, we have Dr. Kenneth Morford, and Dr. Robert Heimer, all affiliated with Yale University. Their chapter titled COVID-19 and the American Overdose Crisis explores the impact of the pandemic on those struggling with the substance use disorder, particularly focusing on how existing disparities were intensified during the pandemic. But first, this episode is sponsored by Okera Coffee, that's UKIIRACOFFEE. Use code 7SAVE10 for your first order at shopokeracoffee.com. That's SAVE10, SAVE10, one word, at SHOPUKIIRACOOFEE.com. So let's get started and hear from each of our guests. Briefly tell us about your background and what drew you to contribute to this book, and then we'll get into an extensive discussion about your chapter. So let's start with you, Emma. Tell us a little bit about yourself.
Sure. So my name is Emma Biegacki, and I am program manager for the Yale program in addiction medicine at Yale School of Medicine. My background is in public health practice and sort of program evaluation with a focus on social determinants of health. Prior to the work that I currently do, I was working more in the HIV space and sort of got into the field of substance use disorder treatment, prevention, harm reduction through that. And in terms of the chapter, this opportunity came across my desk now a couple years back. And substance use and overdose is one of the most pressing public health challenges of our time. So it seemed like an excellent opportunity to talk about the relationship between the overdose crisis and the COVID-19 pandemic, and also to get that story in front of a public health audience, and particularly an audience of students, who may be considering a career in public health and have an interest in the subject matter.
Thank you, Emma. Welcome to the show. How about you, Robert?
Hi, I'm Robert Heimer. I'm professor of epidemiology and of pharmacology. My primary appointment is in the School of Public Health. I'm a bit older than Emma, so my experience goes back almost 35 years now to working at the very beginnings of the efforts to legalize safe access and legal access to syringes to prevent HIV. So like Emma, my experience comes to this beginning with the HIV epidemic in drug users, an epidemic that we've really successfully, in this country at least, turned the corner on. It is no longer the catastrophic problem that it was in the 90s when we started our work. There are still sporadic cases, there are still outbreaks, but in places like Connecticut, with active syringe service programs and proper treatment for people who do become infected, we've decreased the incidence of HIV in drug users by 97.5%. So I'm working mostly on the substance use issues now.
Fantastic. And lastly, Kenny?
Yes, thank you, Caroline, for having us. My name is Kenneth Morford. I'm an assistant professor at the Yale School of Medicine. I'm a physician, so I'm board certified in internal medicine and addiction medicine. In terms of what I do clinically, I work primarily at a large opioid treatment program, and I provide primary care and addiction treatment services primarily for people with substance use disorders. I also take care of patients in the hospital on the addiction medicine consult service. And then in terms of my kind of role at the med schools, I'm a clinician educator. So I direct a number of our addiction training programs for medical, nursing, and PA students, as well as our internal medicine residents and addiction medicine fellows.
Awesome. So excited. It's good to see folks who are also in HIV like I am. And today we get to talk about substance use. So I'll start with you, Emma, as we delve into the chapter. So it highlights social and racial disparities in substance use disorder risk and adverse outcomes. So tell us more about how the COVID-19 pandemic specifically intensified this for people of color struggling with substance use disorder.
Yeah, so this is such an important question. I'm really glad that we're starting with it. It's also a really big question. And I think to really grapple with it, we kind of need to take a step back, right? And look at the scope of the problem first and sort of do some grounding and some numbers and historical background. So in the US in a given year, about 10 to 12% of the 20 plus million people in the US who have a diagnosed substance use disorder receive any form of treatment. That's 10 to 12% of 20 million plus people, right? And that's just folks who have a diagnosed substance use disorder. We know that substance use occurs on a spectrum, and not everyone who uses drugs is going to develop a substance use disorder. We also know that there are folks who might not meet diagnostic criteria for substance use disorder, but may benefit from access to harm reduction, treatment, and prevention services. And we've been living in an overdose crisis now for quite some time. To give a quick stat, between 1992 and 2022, we lost around 840,000 people to overdose deaths. And to give just sort of a quick and dirty overview of the history of the overdose crisis in the US, we can understand the crisis as occurring in a series of waves. I'm not going to go into extreme detail on the nature of these waves for the sake of time today, but you can certainly read the chapter for more information about each of these waves. Briefly, we sort of started with a wave that encompassed an increase in prescription opioid use, brought on by a series of policy and practice changes around how we were approaching pain treatment in the US, amongst various other factors. We then saw that transition into a wave where we were predominantly seeing overdoses related to heroin use. And from there into high potency synthetic opioids like fentanyl, which is still ongoing today, this fentanyl driven overdose crisis. We have an emerging fourth wave that we're seeing now involving high potency, the synthetic opioids, such as fentanyl and other formulations, stimulants, and other novel adulterants. And this is kind of all occurring in the context of polysubstance use and an evolving illicit drug supply. And this, in and of itself, encompassing decades, right, is a very simplified framework. It's not the full picture. It's a good way to kind of understand where we've been and where we are currently, what we might expect to see in the future. And again, the chapter goes into much more detail about the history of each of these waves and sort of how they relate to one another. But to the point, to your question, our chapter discusses social and racial disparities that exist in several key areas relevant to substance use and substance use disorder. And there are three that I really want to highlight. So disparities related to the experience of health-related risks and adverse outcomes, things like developing a substance use disorder, experiencing or dying of an overdose, acquiring an infection like hepatitis C or HIV from substance use, experiencing social risks and adverse outcomes. So losing social or economic capital, say you lose your job or you lose a housing opportunity due to your substance use, you become involved in the criminal legal system by getting arrested and charged with a drug-related offense, and then experience of access to and quality of substance use treatment. So the opportunity to initiate treatment, the likelihood of being retained in treatment, and even the treatment options that you're presented at the outset. These are three key categories where we see social and racial disparities just in sort of the arena of substance use and substance use disorder, not even sort of getting into the pandemic quite yet, right? It's important to acknowledge that these disparities are longstanding. They reflect fundamental inequities in our society that are rooted in structural racism and manifested in racialized drug policies. And they're also compounded. They're compounded by other factors that influence the experience and outcomes of people who use drugs in the US, regardless of their race, stigma, drug criminalization, classism, et cetera, all of these factors influencing the experiences of this population, with particular disparities in the sort of impact of that experience felt across racial and ethnic groups. So all of that background, right, to summarize, at the start of the pandemic, when COVID-19 was just beginning to emerge, the overdose crisis had already been ongoing, and we had these long-standing, pretty entrenched disparities that were shaping outcomes, as well as treatment access and quality, and that were felt differently across different racial and ethnic groups. And we know that large-scale emergencies like a pandemic exacerbate pre-existing disparities. We've seen this before. Really excellent examples that you can find in the public health literature would be Hurricane Katrina, Hurricane Maria, the Flint water crisis, and many more that I could list. But COVID-19 was no exception to this. Emergencies strain the weakest parts of our system. They press on fault lines that are already sort of built into the foundation. It's sort of like pressing on a bruise. So the COVID-19 pandemic absolutely exacerbated these pre-existing disparities that we see in the experience of substance use and substance use disorder and related harms that occur across different racial and ethnic groups. And there's a few key ways that it did that. One would be disruption to access to prevention, treatment, and harm reduction services. So making it harder, right, to stay safe and plugged into care. The pandemic caused a lot of disruptions in the way that we deliver treatment services and the ways that people access harm reduction resources and supplies. The pandemic also disrupted access to basic needs. It made it more difficult for people to keep their jobs, more difficult for people to keep their kids in school. Childcare was disrupted, transportation was disrupted, and all of these things introduced stressors and instability into people's lives that exacerbated some of these pre-existing disparities, and also, introduced new sources of, stress and other factors that had an impact on substance use behaviors. So people of color who use drugs in general saw a higher risk of contracting COVID-19 and experiencing serious illness than their white counterparts. And it's important to understand that there was sort of a synergistic effect going on. Having a substance use disorder, heightened risk of COVID-19 infection for many different reasons to do with different behaviors or activities one might be engaged in around substance use, environment, and other factors related to sort of the impact of substance use disorder on the body. In turn, COVID-19 infection exacerbated the respiratory harms of substance use. So breathing difficulty brought on by intoxication or by smoking your substance of preference, or even by withdrawal in somebody who was also infected with COVID-19, you kind of have this bidirectional impact that had an adverse impact on health outcomes. In two key examples that we discuss in the book relevant to racial and ethnic disparities in the context of the pandemic are differential access to medications for opioid use disorder, specifically methadone and buprenorphine, and the unique risks and challenges that sort of came up during the pandemic response in terms of ensuring continued access to methadone. And the reason that this is highlighted as sort of an example of how racial and ethnic disparities were experienced during the pandemic relevant to substance use is there's been a history of sort of what we would consider to be medication for opioid use disorder segregation or disproportionate access to methadone and to buprenorphine. And methadone is delivered through a system where, for many people, they have to appear in person at a facility every day and line up in a setting where they're in a closed space or in close proximity to many other people. This was a huge problem at the start of the pandemic. How do we ensure that people are able to get their medication and also not expose themselves to COVID? And how do we adapt quickly to change the way that we dispense this medication so that people can stay safe? There's a disparity racially in terms of who's receiving methadone and who's receiving buprenorphine. So the options that were available to people to continue to stay, on their medication, were sort of felt differently. That's one example that's discussed, in much more detail in the chapter. The second example that we'll highlight here briefly is just differential impact on justice-involved individuals, where there were a lot of unique risks during the pandemic posed to people who were incarcerated and people who were exiting prisons and jails. And we know that in the United States, there is a huge disparity in terms of who is incarcerated, and in particular, who's incarcerated for drug-related offenses. We could spend the whole hour talking about this, but I'll stop there.
It's a great introduction, and I think it will set the pace for the questions that come from this. So thanks for that intro, and to follow up with that. So then I want to ask a question to you, Kenny, and Emma has gone into great detail about all those issues and how some of the gaps that we see in substance use disorders. And so this chapter talks about vast and persistent treatment gaps. So could you tell us briefly the pandemic's role in exacerbating that gap? And if you have any examples to show why people have a problem accessing treatment?
Yeah, sure. Thanks for that question, Caroline. And I think, Emma kind of captured some of this. When we talk about this vast and persistent treatment gap, a commonly cited statistic is that around 10% of people with a substance use disorder don't receive any form of substance use treatment. That comes from the National Survey on Drug Use and Health. And it persisted for years, kind of leading up to the pandemic. So when we had the onset of the pandemic, we saw disruptions to all areas of the healthcare system. And so it was no surprise that the addiction treatment system was, affected as well. In some ways, I think it was more affected than some of the other healthcare services for some of the reasons that Emma had mentioned, where, methadone and buprenorphine, methadone especially really relies on kind of in-person daily dispensing. So just to kind of give you my personal experience of this. So I was, I'm a clinician. I was working at my office in this opioid treatment program. The day that the lockdown orders happened, we were basically told, call every patient that you can and try and give them at least a month's worth of prescriptions, if not more, so they at least have medications. And then we're going to try and figure out how we'll connect with them afterwards. And so this is to say that our focus was really just on kind of keeping the people who are already engaged in treatment. I mean, the thought at that point of even trying to kind of expand treatment or initiate treatment for people was really not on the table. We didn't know how to do it yet. So in some sense, I think the potential for losing our existing patients in treatment was kind of expanding this treatment gap. And then it's all of those kind of common things. So we saw closures of different treatment facilities. We saw reduced capacity because especially residential treatment facilities were worried about transmission of COVID. I mean, early on, we didn't even have testing. So it was like, if someone has a cough, do we shut down the whole place? We don't have a way of quarantining people. How do we quarantine people? That all became very complicated. Methadone dosing became complicated. People are supposed to go inside to a building to get a dose. If they show any symptoms, are we allowed to bring the methadone outside to them? If they bring a friend who wants to start treatment, can we have them do a full intake? That requires at least several hours inside of a building. Probably not. So I think those were some of the major barriers. The other thing I'll say is, the transition to telehealth, even though it started in a very kind of rudimentary way, the rollout was pretty impressive, and we did reach a lot of people that way. But there are also a lot of people who just don't have the technology for telehealth. So that was a challenge, right? Like people who don't have smartphones, people who don't have secure housing where they might not have the privacy to be speaking to a clinician was very tough. And so there are a lot of people who benefit from having these in-person interactions that were just kind of shut down. Kind of last couple of things I'll say on this is, in addition to formal treatment, there was also a reduction or kind of cancellation of peer support services. So groups like AA, Smart Recovery, they either canceled or moved online. Same issues with can people access this stuff online? similar impact on harm reduction services. And then I think, this is all happening in the context of like a lot of stress. There's financial stress, housing stress, like health related stress of, am I going to get sick, or do I have this new infection? All of those things can exacerbate a substance use disorder. And that was happening. Meanwhile, we had a constant supply of substances, which was kind of surprising to us. So there are riskier substances out there. People are more stressed. They have limited ability to reach their treatment providers. And so I think all of those factors kind of led to this exacerbated treatment gap, or just kind of like a changing and disrupted treatment system.
Thank you so much, Kenny. And this really helps feed into what else I want to talk about, especially when we think about those pre-existing social and economic inequalities. You talked about housing. You talked about people wondering, what am I going to eat? And so for you, Robert, outside of that immediate disruption that Kenny went into, and what he's explained to us, and what really Emma also described overarchingly, could you talk to us about how this pre-existing social and economic inequalities shaped the impact of COVID-19 on these folks who have substance use disorder?
Okay. Well, when COVID emerged in February, March of 2020, it was exactly 50 years after the inauguration of the war on drugs, which was really a war on people who use drugs, especially Black and brown people. If one looks at the maps and the density of overdose deaths and COVID deaths in Connecticut, they're virtually superimposable. Same neighborhoods with high rates of overdose deaths are the same neighborhoods with high rates of COVID infections and COVID deaths. Those maps are also superimposable on maps of people who are incarcerated or under criminal justice supervision. Now, none of this is surprising given what we know about the how social factors determine health. But it really does say that if we're going in to recognize where the resources needed to be placed to have had an impact on reducing COVID deaths and getting more people into treatment, you would have had to focus on these neighborhoods. And that was just not possible during COVID. And it still isn't being really very well done in most places. It seems very hard to focus our attention and our monetary resources on these communities for reasons that are way too complicated and long-standing to go into. But Kenny mentioned that the substance use treatment services that were the most progressive in the state did everything they could to keep people into treatment. And many of the programs in the state did adapt. They did keep people on medication. They've continued to keep people on medication. And fortunately, at the national level, the regulations on the dispensing of methadone and the prescribing of Suboxone, buprenorphine have lessened to the point where it is possible to reach out and treat more people, but it isn't necessarily translated into more people being on treatment, unfortunately. There are more take-homes being available to people. They don't have to wait months and months and months before they can stop coming every day to treatment. Many of the programs in the state very quickly move people to 14 days between visits, 28 days between visits. And this is sort of sensible. There's no other medications really where we can think of, with the possible exception of directly observed treatment for tuberculosis, where we insist that people come to treatment every day. We basically trust people to take their medications even when they don't. We don't go out and force them to take their antihypertensive medication every day, right? We don't force them to take their insulin, but people on insulin tend to take it because otherwise they'll be extremely uncomfortable or even die. And the same is true with agonist medications for the treatment of opiate use disorder. People who stop taking them go into withdrawal. So the incentive to continue to take your medications over your 14-day or 28-day period of take-homes is rather strong. There's a real incentive to adhere to your medications in this case, which is often not the case for other medications. The big difficulty in some ways and a difficulty that COVID produced was the disruption of social networks, in part brought about by the closure of many places that people who use drugs and other people living in constrained circumstances used to go for respite. Places like public libraries, places like fast food restaurants, cafeterias, even our shelters and our soup kitchens started, it had trouble keeping people in confined spaces. The soup kitchen in New Haven, for instance, started, handing out bags of food rather than hot meals at the front door of the facility, rather than letting people in. And so there was the sort of normal social lives of people were disrupted. A lot of people retreated to who were housed retreated to moving indoors. And the one thing we've learned about overdose deaths is they're concentrated in people in residences, their own or other people's residences. Because when they use alone, there's no one there who can recognizes that they're having an overdose, has naloxone, Narcan, the antidote that can keep them from dying and can administer it to them. So in this state, 70 to 75% of overdose deaths occur in residences. It's not a problem that is easily solved, but it is a problem that we recognize and are struggling to figure out ways to solve. So obviously, even though I guess it's typical in some ways of public health, we can recognize a problem. Devising an effective solution is always more complicated, because by the time they become serious public health problems, they're long-standing, they're entrenched, there are cultural issues that are very, very hard to manage and to overcome. I think that your initial question about the inequalities, they persist. We're seeing an increasing rate of overdose deaths in our inner cities over the last 4 or 5 years compared to the way it was distributed, say, 10 years ago. And that's despite enormous efforts of harm reduction workers and programs in those cities to get naloxone into the hands of people. Unfortunately, the last couple of years, the number of overdose deaths in Connecticut have decreased by about 7% the first year, 8% last year, which is great news. And I hope that's sustained. But it has required an enormous amount of work of getting naloxone out into people's hands, naloxone into residences where somebody can witness an overdose if it happens, and respond, changing the way the first responder system works to get to people and administer naloxone more quickly. And all of this, because we're still just emerging from the COVID period, I hope it can be sustained, but I'm not sure, and we'll be monitoring that in the future.
Wow, I appreciate that. Also, thinking about 50 years of doing this, dealing with substance use disorders or just substance use. Um, that's fascinating. That's older than me.
It's frustrating. 50 years we've been walking down the wrong path.
Yes. And then you think about all these social determinants of health. Think of the multiple issues. And like you said, you feel like you've moved 10 steps and then it's 20 steps back. And Kenny, some of those barriers have been highlighted by Robert, but I wanted to, just ask you, knowing that the chapter talks about all these existing issues or substance use treatments exist despite low access rate. Any other barriers you can think about? But I think most importantly is how do these barriers, how can they be addressed in a post-pandemic world? Not sure we're still in a post-pandemic world, knowing public health. For purposes of this discussion, what's a post-pandemic world?
Yeah, fair. Yeah, great questions. When we think about kind of key barriers to accessing these treatments, something that both Emma and Robert have alluded to is that there's let's step back to this treatment gap. So the reasons behind the treatment gap, they are complicated, but from that National Survey on Drug Use and Health, the majority of people who don't receive treatment, who need treatment, don't seek it out or don't think that they need it. That's why people aren't going to treatment. And, I think to unpack that really gets to issues of stigma and lack of knowledge. So, and they have kind of asked additional questions on the most recent survey of like, why, if you were to seek treatment, like what would keep you from doing that? And some of the answers have to do with like, well, I don't want my friends or neighbors or families to know. So I think it's interesting where this is a condition where, when we think about addiction, there's kind of three forms of stigma. There's like the stigma towards the individual who's using substances or has a substance use disorder, is like they're hopeless. It's a decision that they made. It's a willful choice. It's not this kind of treatable disorder. There's a stigma around the condition itself, that it is something that can't be treated. And then there's stigma around the treatments for the condition, right? So like methadone and buprenorphine have a lot of stigma. People are like, this is replacing one addiction for another, but in fact, it's stabilizing people. So, I think that there's kind of societal stigma, there's internal stigma, and then we see stigma from clinicians who feel like they don't want to provide these medications because they either don't believe in them or don't know how effective they can be, or they just don't know how to actually deliver these treatments. So I think stigma remains probably one of and this like lack of education remains the biggest barrier to kind of close this treatment gap. And then I think some of the more kind of basic stuff, like limited availability of services. So we really see that in rural areas in the US. Like there's some places that don't have a methadone program. You have to drive like 3 hours to get to one. So that's an issue. Financial barriers. So depending on which state you're in, if there's Medicaid expansion, if there's a way to have insurance coverage for these substance use services like that, if you don't have coverage, then people might not seek them out. So in terms of addressing the barriers in a hopefully post-pandemic world, I do think that there's a lot of role for education and stigma reduction, both kind of like public education, but one of the areas where I focus on is educating healthcare professionals. So both students as well as practicing clinicians, to equip them with the basic skills of how to care for people with substance use disorders, understand the whole spectrum of treatment, be able to prescribe these meds, provide harm reduction counseling and supplies. Like those are things that any clinician really can do. We just weren't taught it. When I was in med school, I was not taught that. So I think that's something that all health professional schools should make a mandatory part of their curricula. And there's also a role for specialized training. So addiction medicine and psychiatry fellowships, we want to have champions who can go into a practice setting that's established and become the champion for addiction treatment and start to allow kind of more access to treatment in places that don't have it right now. And then I think other ways to address it, not to kind of spend too much time, but continuing expansion of telehealth services, I think is critical. Studies that have come out since the pandemic have shown that initiation and treatment with buprenorphine for opioid use disorder through telehealth is associated both with improved treatment retention, so people stay in treatment, and reduced overdose deaths. So, we are seeing positive outcomes of telehealth, substance use disorder treatment with telehealth. I think for now, the DEA has allowed the telehealth initiation of buprenorphine to go until December of 2024. So I really hope that that continues beyond then. I think that should be permanent. I also think that the methadone take-home doses that Robert mentioned should be permanent. We should allow people to get up to 28 days of take-home bottles like any other medication. And then, there are some other kind of policy and regulatory areas around how to expand methadone dosing. So I think those are some of kind of the main ways we can go about improving, access and reducing barriers.
Fantastic. So thinking of those policy issues, I'm still pondering on, lack of knowledge, maybe increasing that knowledge, thinking about stigma, and then looking at how this mirrors the HIV pandemic as well. And as you think about those last comments that you're going to make as we start ending the podcast, Emma, I'm wondering, what you have in mind in terms of these lessons learned for future policy and practice. We want these strategies to be sustainable, and we know that it's important to come up with policies to help with that. So can you share one actionable recommendation that this chapter proposes to improve access to care and reduce disparities for those who have substance use, I think? But you're going to solve this for us today.
And I'll do it in 30 seconds or less. So, I think Kenny kind of started to answer this question a little bit, and I'll pick up where he left off. A lot of the questions preceding this one, we've kind of outlined maybe a little bit of a doom and gloom, idea of all of these disparities that are at play, disparities that preceded the pandemic and were compounded by the pandemic, and that we continue to see play out in this sort of pseudo post-pandemic stage that we're in. But the reality is that the pandemic catalyzed a period of policy and practice innovation in substance use treatment and prevention and harm reduction that we, have been striving for quite some time. The pandemic has really set the stage for a paradigm shift in terms of how we approach substance use and addiction. And in addition to sort of scaling and continuing some of the innovations that Kenny outlined, around telehealth and some of the adaptations that we saw take place sort of in the methadone OTP system and whatnot, there are other areas in which we have room to grow. And a lot of it has to do with following the evidence. Part of the reason that we wanted to start this conversation from a bird's eye view and really drill down from what is the state of substance use disorder and overdose in the US, all the way down to what are sort of the disparities that are impacting, individuals' outcomes, is because we have treatments for substance use disorder. Substance use disorder is a treatable disease. We have evidence-based harm reduction interventions that work. We just need to follow the evidence, and we have a great deal that we can learn from our global neighbors in that. We have a number of, other countries around the world that are doing amazing work that we can learn from and that we can potentially bring to the US and implement. Some of those things include expanding access to medication treatments that are currently unavailable in the US, but that have good evidence behind them, scaling implementation and impact assessment for services that facilitate safer consumption in the context of a rapidly evolving illicit drug supply, things like overdose prevention centers and safe supply programs. And above and beyond that, something that we at Yale really emphasize in our program's work that spans clinical practice, research, education, and policy is the vision of there being no wrong door for substance use treatment. If we can expand comprehensive substance use treatment into general medical settings, primary care offices, emergency departments, if we can expand integrated care models where someone who's receiving services for an infectious disease such as HIV can also attend to their substance use in that same setting, as one example, this can meaningfully boost access to care. It creates a world in which no matter what door you're entering through, you're going to be connected to services that can help you with your substance use. And given Kenny's comments, I would also add to that, that there should be no wrong door to substance use education. We have a lot of work still to do to ensure that our health professionals, no matter what path they're on, no matter what type of provider they are training to be, are exposed to substance use education in their training and come out the other side with an understanding of how they and their role can contribute to addressing addiction and overdose in their career. So I'll pause there and see if Kenny or Robert have anything to add to that.
Yes. Any additions to that, Kenny, Robert?
Well, I mean, Emma started with the notion of there being no wrong door to treatment. I think one of the issues is what happens when you go through that door. There's a range of treatments options available to people, and not all of them are equally effective. There's a great deal of stigma around the medication-based treatments, methadone, buprenorphine. That has to be reduced. The ideal that an abstinence-based treatment to be clean, to be in recovery where you don't use any substances or any drugs or any medication to manage your use disorder is intrinsically flawed. We know that opiate use disorder especially is a chronic relapsing condition that when people are under stress, they will resume drug use. The 90% of the people who stop using drugs start again, opioids within 6 months. We've done studies that have demonstrated that abstinence-based treatment is actually more dangerous than no treatment at all in terms of overdose deaths by a factor of about 70%. While the medication-based treatments, even if if you're exposed to them in the 6 months prior to death, your likelihood of dying your likelihood of dying is reduced. Not if you die, but if you don't die, your chances of dying are reduced if you've been exposed to a medication-based treatment versus no treatment at all. So we know that medications work. We know that the stigma around them prevents their use being more widespread. Even though we've, and this has been mentioned now several times, made it easier to prescribe them and easier for people to get take-homes, we haven't seen a huge increase in the number of people in this country who are receiving methadone or buprenorphine. And a major reason for that is that it is a stigma against these medications. And I think in some ways, and I know this is controversial, the recovery community is responsible for this by creating this unsustainable, perfect treatment. And, it's an old saying that don't let the, perfect be the enemy of the good. Well, this is certainly the case with substance abuse treatment, that yes, being abstinent is lovely. And if you can sustain it, as we say, mazel tov, but it's not sustainable for most people. And medications do work and they save lives. And until we stop thinking about people being in recovery, but rather that they're in remission from a chronic disease and that the medications are there to keep them in remission, that would be better than thinking about recovery, which I tend to think about as something you do with a broken arm or the flu, not a chronic condition.
Right. Wow.
But there are four other things I think that you need to do in order to really address this problem. And I'll try to be succinct on these. The systems of treatment have to be put in places where people can get them when their risk of overdose is the highest. And what we've learned is that's within 1 to 2 days after release from incarceration or within a week after a non-fatal overdose. We really have to have systems in place that reach out to those people. Either we start them on, and there are studies that have shown starting people in carceral settings with medications improves their outcome once they get out. That has to become more widespread but there also has to be transitions that occur more quickly from treatment in the carceral situation to treatment in the community. You can't let people lapse from their treatment that is started inside jail or prison and then isn't continued in the community. The second thing is that while it's nice that well, it's not nice. We've been strapped with a methadone delivery system that is completely inappropriate to the medication. Why can't you go to a pharmacy to pick up your dose of methadone? You certainly can go to pick up your dose of oxycodone if the doctor prescribes it, for, post-surgically or something. To force it to be behind a silo, like an opioid treatment program, is a big barrier that stops people from coming and using the service. We did begin to mention that other forms of agonist medications, not just buprenorphine and methadone, need to be tested in the United States. We already know they work in lots of other countries. Controlled heroin trials have demonstrated the effectiveness of treating people with heroin. I love the study that the Dutch did, where at the end of a year on heroin, the reporting team reported that the health of the people who'd been on heroin for a year was indistinguishable from the Dutch community of the same age. That basically you can treat people, you can keep them and get them healthy, and then you have to sustain that health over long periods of time. But first, you've got to get them into treatment. And finally, and this was mentioned once before, about safe consumption spaces or opioid prevention sites. There's never been a fatal overdose in one of them. U.S. lags behind the civilized world in implementing these. And while they're not a panacea, they play multiple roles in the opioid crisis. On safe consumption under medical supervision, the benefits in preventing overdose is obvious, but the added benefits include decreases in public drug consumption and public disorder, increases in drug treatment initiation directly from those safe consumption spaces. And if the resources are available, those safe consumption sites can have medical services so we can attend to the other medical problems that plague people with opiate use disorder, things like HIV, hepatitis C, soft tissue infections, and other chronic manifestations of unsafe drug use. And I think with that, we've basically gone from the sort of safe area of talking about expanding treatment to a more controversial area. But I think without having all of these tools available for us, it's going to be a much longer road to bringing down substantially the number of overdose deaths in this country.
Wow. I wish we had more time, but that means we have to have a part two and discuss so much more and even maybe identify ways to combine treatment and other perspectives, like the controversial needle exchange program. So really happy that we had this conversation today. Extremely fascinating and enlightening. The information you all provided about the challenges faced by people with substance use disorder during the pandemic and the existing disparities is extremely stark, but essential to understand. And we ended on a hopeful note, but also there were challenges and questions that need to be answered on this 50-year journey. So those actionable steps are really helpful. So thank you again, my guests, for joining us on Public Health Musings. It's been a pleasure to know you and have you all on the show. And I want to thank the listeners for tuning in. Remember to subscribe to the podcast on any of your platforms that you listen or watch. And you can also find the book, COVID-19 and Public Health, at Ohio University, Ohio Swallow Press, Amazon, Barnes & Nobles, and other bookshops. So thank you again to everyone, and I'm looking forward to seeing you all on another episode of Public Health Musings. Caroline Kingori.